see, we have 1, 2, 3, 4, 5, 6, 7. Am I counting right? 8. We certainly have quorum.
Okay.
Maybe just another minute.
Sure.
Here comes Rena. Good morning, Rena.
Good morning. Good morning. All right.
Hey, I think and we certainly have quorum whenever you'd like to go ahead, Lauren.
Sure. So good morning, everyone. I hope everyone is doing well. Before we call the formal meeting to order, we need to recognize that this meeting marks the transition of one of our longest serving board members. And I believe that Nancy wanted to open up with a few remarks. So I'll turn it over to Nancy.
Great, thank you, Lauren. Good morning, everybody. So as Lauren said, I wanted to take a moment to recognize that our meeting today marks the end of an era. Lou Malzone has left the board, and he was, with that departure, we have lost our last original Health Connector board member. And Lou was among the group of what was then 10 original board members appointed to the board by the Attorney General back in 2006, just after the passage of the Health Reform Law, Chapter 58. And I think, you know, for the many of us who were involved, it's, I think, important to reflect back that all those were very heady days. They were actually really uncertain days too. Massachusetts had just passed the most ambitious attempt by any state to expand coverage, but now the state had to implement it. And this body was one of the innovative things that law created, the first state-based health insurance marketplace. And other provisions of law, particularly the individual mandate, were really novel and untested and uncharted. And so I think the decisions that were made by Lou and those other 9 original board members, particularly in that first year, I think were absolutely critical to the law's enduring success. And so with Lou's departure, I really think that we should recognize and thank that. Throughout his time on the board, Lou has been a really strong and very reliable consumer voice. And so Healthcare for All wanted to recognize and thank Lou for his service. And they asked me to read some short remarks. So I'm sorry Lou isn't here to hear this, but I'll be sure to follow up with him afterwards. They write, "Dear Lou, on behalf of Healthcare for All, we want to thank you for your many years of service on the board of the Health Connector. You have been there from the beginning. You have seen it all. We are grateful for your partnership and for your commitment to increasing access to health coverage and care for hundreds of thousands of individuals and families in Massachusetts. You have been part of an incredible effort that is a model for both national and state-based policy, and we hope that you take great pride in that. We wish you all the best as you move on from this role. With appreciation, the staff and board of Healthcare for All." And then I just wanted to mention in particular one very consistent theme in Lou's tenure on the board, and that's been his advocacy to try to make health plan choices simpler and easier to navigate for consumers. And although he was appointed to the slot on the board that's for employer health benefit experts, I actually think he showed incredible expertise in consumer psychology over his years on the board. Understanding of what in psychology is called the paradox of choice, which is that if consumers have too many choices, it causes stress and anxiety and actually makes it very difficult for them to make good choices. As many of you know, he often expressed that view using an ice cream metaphor, where he would admonish us that we don't need 31 flavors, we just need the basics, vanilla, chocolate, and strawberry. And he would say, how many flavors of vanilla do we need anyway? So I thought it would be appropriate to pick up on that theme of ice cream and give Lou a little token of appreciation. And Kathy, I don't know, are you going to show it or you want me to show the
You can
slide?
show.
Okay. All right. So we made Lou a little poster that we're going to give him on behalf of the board, which is Lou's 3 flavors, vanilla, chocolate, and strawberry, eliminating 28 other flavors that we know Lou would not approve of, which include Rocky Road High Deductible, Surprise Billing Brittle, Lemon Limited Network, and Cookie Dough Select. And the poster reads, with thanks to Lou Malzone, Health Connector Board Member 2006 to 2020, expert on the paradox of choice, wise advocate for simpler and more affordable health insurance choices for consumers. So I'm sorry that Lou couldn't be here. He may be glad he's not here. But anyway, so we'll send it along to him with our thanks, and really for the many contributions he has made over many, many years to make the health insurance system in our state more just and more fair. So Lauren, thank you for letting me say a few words.
Here, great, thank you, Nancy. And thank you to Healthcare for All for providing over those remarks. So before, I just wanted to open up to see if there were other remarks from board members that folks wanted to note before we move into our formal board meeting.
Yeah, Lauren, I just want to say a couple of words. I didn't know Lou was retiring off the board. I appreciate Nancy and the kind words shared about Lou. He and I haven't always been on the same side of the discussion, but I always found him to be professional and a gentleman. And I guess, I don't know, I didn't know he didn't like coffee ice cream, and that really upsets me, Nancy, because I love coffee ice cream. So that's just another reason, another thing for Lou and I to talk about someday. But I'm very grateful for the opportunity to partner with him on the board, and have enjoyed the intellectual debates that we've enjoyed over the years, and I wish him the best.
Thank you, Mark. Anyone else? All right. So with that, I will go ahead and call the meeting to order. And I believe that we need to do a roll call vote for members present to be, is that correct? That we need to do a roll call to commence?
Yes, Kathy, could we go through the roll?
We sure can. Commissioner Anderson,
Good morning here.
Michael,
Here.
Fay Ruth,
Oh, it looks like you may have gone on mute too fast.
okay, she's there. Cassandra,
Here, good morning.
Dimitri. No Dimitri. Lauren,
Yes, present.
Nancy,
I'm still here.
Matt,
Yes, I'm here.
Rena,
I'm here.
and Zarani.
I'm here.
And Mark on you.
Oh, I'm sorry, Mark, I missed you.
No, that's okay, Kathy. I'm here.
Great.
Just don't like
Thank you.
coffee ice cream either, Mark.
Great. Thank you, Kathy. And so the first item on the agenda is approval of the minutes from the July 9th board meeting. So I will go ahead and entertain a motion to approve the minutes.
So
So
moved.
moved.
Do we have a second?
Seconded.
Great. And can I turn it over to you, Kathy, for the second of several of these roll calls?
Sure can. Commissioner,
Yes.
Michael,
Yes.
Fay Ruth,
Yes.
Mark,
Yes.
Cassandra,
Yes.
Lauren,
Yes.
Nancy,
Yes.
Matt,
Yes.
Rena. Rena? Okay.
Yes, I'm on mute, sorry.
Okay, and Zaranique.
Yeah.
Okay,
Great. So the motion carries and the minutes are approved. The next item on the agenda is the Executive Director's Report, so I will turn it over to you, Louis. Up, and you might be on mute.
Good morning, thank you. And I want to start by adding my own note of thanks to Lou Malzone for his role in fostering health reform in Massachusetts all these years. One of the things I always appreciated about Lou was he had the ability to be very direct and very candid, while also being just very personable. And I really appreciated his advice over the years, and just want to wish him the very best. And I welcome our new board member appointed through the Attorney General's office, Zaranique Watson-Pope. Zaranique currently manages human resources at Dot House Health, a nonprofit community health center in Boston. She brings a wealth of human resource and health insurance knowledge to our board, having previously worked at LifeStance Health, Steward Healthcare, and at Veterans Affairs New England Healthcare System. We look forward to working with you, Zaranique, and are grateful to add your experience and background to the board. And if I got anything wrong, or if you'd like to add anything, please feel free at this time before we go further.
Nothing to add, just thank you for the warm welcome, and I'm really looking forward to working with everyone.
Thank you, Zaranique. I'd like to start today by focusing on the current status of our customer service operations, and particularly the call center. It has been 2 months since we transferred our premium billing operations to Softion and our call center to a firm called Faneuil. Thus far, the contact center performance remains unacceptable. It has become clear that Faneuil is not yet adequately able to operate a remote workforce, and our members deserve better performance. We are working to make that happen. We are undertaking multiple interventions, one of which includes placing Faneuil on a formal corrective action plan to address contract deficiencies. Another includes support from Accenture solicited through a public request for quote from state blanket agreements to assess call center performance and conditions. Last week was the call center's strongest to date, with abandonment rates around an acceptable 1%, but work on backlogs and other issues continue, and if the corrective action plan is not met, additional interventions are contemplated. As we move past Labor Day and into the fall, we turn our attention to open enrollment and making sure our members and new applicants have the tools and service they need to be in the right coverage for 2021. Today, we will ask for your vote on the seal of approval for 2021. This includes 9 carriers and 59 non-group and 72 small group plans. So we're still not quite at vanilla, chocolate, and strawberry, but we think there are reasons why this may be appropriate this year, similar to last year. Additionally, we will seek your vote for 4 dental carriers and 19 dental plans. While the breadth of plan selection remains consistent, I do want to note there are some material changes that will be important to our members. In connector care, Health New England is expanding its coverage into Worcester County with competitive rates that make it the lowest cost option in the new coverage area. AllWays is contracting its connector care coverage, contracting its connector care coverage, and is moving out of Worcester County, which will impact about 550 members who will need to move to a new connector care offering. In other areas, AllWays has enlarged its select network for 2021 beyond its initial outline to us, addressing our staff's duty to assure connector care network adequacy standards. However, the new network does not mirror its 2020 network, which will create some disruption for some connector care members. Based on final rates put on file by the Division of Insurance in August, in many areas across the state, Boston Medical Center Health Plan now becomes the lowest cost plan in many of our regions, including throughout most of the greater Boston area, out to $495. With plans in place, we will also discuss today readiness for open enrollment, which will look quite different during an ongoing pandemic. Staff will provide a review of the work underway to support a successful open enrollment, including technical system updates, eligibility and enrollment changes for members, carrier engagement and enrollment transaction processing, and communications and outreach, including announcing the new 2020 through 2022 Navigator program participants, which will provide community-based support to residents across the Commonwealth. We've been trying out and preparing new virtual alternatives to outreach and assistance for open enrollment, including potential further expansion of Navigator capacity to meet needs while our walk-in centers remain closed. We will ensure member messaging provides appropriate detail and support to members who need to update income, provide documents, or file taxes during what has been a confusing and stressful period for members who may need to take steps to preserve coverage for 2021. Finally, we'll wrap up with a high-level overview of policy updates for the board. And as always, thank you for your guidance and insight as we move into our next open enrollment, which assuredly will look different than any other in the past. And so I'm certainly open for questions, or I can yield back to start our presentation.
Any questions? All right, thank you, Louis. So the next item on the agenda is an update on the customer experience project, which will be presented by Vicki Coates. So, Vicki, can I turn it to you?
Yes, thank you, Lauren. Good morning, everyone. If we could go to slide 1, please, Erin. So as reported at the July board meeting and in the most recent board metrics report, Faneuil has significantly underperformed against all our key indicators for the past 2 months. The key drivers of this underperformance are attrition, high attrition at all stages of employment, particularly during training and after initial transition to the phones, high absenteeism, lack of staff adherence to schedules, and as Louis said, really Faneuil's ability to effectively support and manage staff now that we're in a 100% remote setting. As Louis said, we have been and continue to work with the highest levels of leadership of Faneuil on this, and we have instituted a formal correction active plan, which is under our rights in the contract. Can you move to the next slide, please? So we've met with Faneuil a number of times and made clear our expectations that September needs to be different. Faneuil has put in place the following actions to do that, but most notably on the call center front, added 2 classes the last week of August, which will train and bring on 64 agents by September 20th, which is our payment deadline week, so that we have acceptable performance in the call center. They have offered incentives for working overtime on the high peak Mondays, and also measures for adherence to attendance. The other thing that we have been working with them on is processing inventory. While folks have been working on the call center, we have had the inventory move up, so they've brought on additional staff with that. And they have a backlog inventory plan that they've presented to us, which calls for inventory to be within acceptable bounds by September 18th. We have made it clear to Faneuil our expectation regarding September, and that they must meet their projected targets for September for both the call center and inventory. Would you mind moving on, Erin? As important as focusing on September with Faneuil, we also need to have a path to required stabilization and performance ongoing. So we have a formal corrective action plan in place. We've asked Faneuil to propose in that corrective action plan and implement changes which address the operational concerns and performance gaps. The areas in the CAP of a note to the board would be analyzing and addressing root causes of attrition and absenteeism, analysis of CSAT and drivers of performance, identification and institution of work from home management best practices, and retraining staff in key content areas. In addition to working with senior leadership at Faneuil and the corrective action plan, the connector engaged Accenture to evaluate Faneuil's readiness for open enrollment, since open enrollment is a few short weeks away. Accenture has found a number of gaps that need to be addressed, and we are actively working now with Faneuil regarding a set of remediation actions to be taken in time for open enrollment to address the gaps found by Accenture. That's really the presentation for this morning on call center. We're actively managing this with Faneuil. I would take any questions.
Vicki, thank you. This is Michael. Two things. First of all, this is obviously disappointing to hear. I understand both for this meeting and other in the pre-call that you are certainly on top of this and pushing very hard, which I wholeheartedly support. My question for you is some combination of how can we help and what's the information flow going to be between you and the board as we go through the next few critical weeks?
Vicki, if I could take an opportunity to respond. Thank you, Michael. Our communications with the board are certainly at your discretion. In other words, we're happy to be more thoroughly engaged in keeping the board in the loop as to the interventions and can do that on a weekly or other basis of your choosing. I would propose weekly to start. I think there will likely be the need for additional interventions. The bid that Accenture responded to will allow it to provide additional supervisory or management supports. And we are considering that. And so I think we would look to the board's guidance as we undertake additional measures to bolster call center performance heading into open enrollment.
So the key thing, thank you. I know Nancy has a question, but the key thing I just want to say is that I realize this will go reasonably quickly, and this is something that's happening on a daily, if not hourly basis, this process. So I think it's important to go on record that you have our support, my support, I won't speak for everyone else, my support in the actions that you take. And the key is to make sure we're there to help you as you sort through this.
Thank you. Thank you, Michael.
Yep, thank you. And just to build upon that, I think that at this point, weekly updates would be appropriate, just as we help to, or to the extent that we can help stabilize the situation, and then we can reevaluate. But weekly updates for the board would be advised.
Understood. Thank you.
Nancy, did you have a question?
I did. So how much of this is COVID related and the transitions, the difficult transitions we've all been going through to remote work and management in a remote setting? And in light of that, as we contemplate an open enrollment that's going to be largely remote, that's going to involve not only the usual populations, but a significant number of people, I think, who have been laid off or furloughed now, but will be laid off. The complexity of that environment. If it's related to lack of capability and capacity to work in a remote environment, what do we need to do to be sure that as we move into a remote open enrollment environment? That's the first. And the second is, based on this, do we have any concerns that any capabilities were misrepresented by Faneuil?
Vicki, again, if I could take accountability. So two things. I do think that a fair amount of what we're seeing may be related to the remote workforce management. Faneuil, as you know, came with particularly excellent recommendations from other state clients. And Faneuil has traditionally managed well, to our understanding, in a brick and mortar environment. I do think managing a remote workforce is very different, and I don't think that Faneuil has yet fully grasped and established control over that process. I know that it's possible because in our contact tracing work, our call center is entirely remote. And after some initial difficulties managing a remote call workforce, Accenture has been very good in bringing order to all the processes relating to workforce management and supervisory input to the process. And so I know it's possible to address these issues, but that it does take strong, experienced remote call center management. But I think these are not little difficulties. I think there are difficulties across the board. And so I think I'll be candid in saying I think the likelihood of the need for Accenture augmentation is very high. With regard to your last part of your question, I don't know. I'll be honest in saying I don't know if misrepresentations were involved. I do find that Faneuil senior management has been oriented to trying to do the right thing, being responsive in terms of their interactions with us. But at the same time, I think the kinds of changes that are going to be needed to make this really work for open enrollment will push them very far in terms of their traditional methods. So I regret that I can't conclusively respond to the last part of the question, but this is what I do know.
Thank you.
Can I offer up a couple comments? We do a lot of work in our business with employers of all shapes and sizes. And frankly, they're all struggling with the whole transition to remote work. So this is not a unique phenomenon to Faneuil. But what I have seen in our experience of those that are succeeding in this new environment is those that have a strong culture, connectivity with their employees. They focused on their people. They've enabled their people with mechanical capabilities to be connected. They've set up opportunities to interact with one another. And if that's not part of the culture of Faneuil, that's not how they behave, it's going to be very hard for them to turn on a dime to make an adjustment of the order of magnitude that we're talking about, Lewis. So, it's not an excuse for them. What happened with COVID, it speaks more to the way their operation may or may not be running with regard to how they interact with their people. So I would be one who would be very concerned about their ability to correct what we've bought.
And I fully acknowledge that, Mark. I think you're right.
Louis, one question for you. I recall back in July, NTT had provided something in the order of 90 employees temporarily to help with the issues that we were experiencing. Are they still involved, and will they play a role in open enrollment?
I'll ask Vicki if she can give us the latest on that. My understanding is that they are still involved. Vicki, do you want to elaborate?
So they're subcontracted directly to Faneuil, Cassandra. They're still under that subcontract. And they're in the headcount that's answering the phones and processing inventory today. And they're part of the headcount projections up through the end of January. They too have had some attrition because the contract is temporary, but we do count on them to be part of the customer service complement through February. And one of the things that we are asking Faneuil for is a formal knowledge transfer from the leadership that was inherited from NTT to Faneuil, because they obviously know our program.
Great, thank you.
Okay, thank you very much. Thank you all for your help and support. Appreciate it.
Great. Thank you, Louis and Vicki, for this update. All right, the next item on the agenda is the Plan Year 2021 Final Award of Seal of Approval presentation. So I will turn it over to Maria and Samuel for this update.
Great, thank you, Lauren, and good morning, everyone. So today we bring before the board our recommendation for health and dental plans to be awarded the final seal of approval, which is the last presentation in the seal of approval process. Today's vote will allow us to proceed with selling the plans proposed beginning with the 2021 open enrollment period in November. We'll describe today any changes since the July board meeting, including carrier network and structure changes, as well as provide an overview of 2021 premiums and the proposed 2021 Connector Care program. So key features of the 2021 seal of approval include a Connector Care program that, despite some changes from 2020, continues to offer affordable selection of at least 2 carriers in many regions, a wide array of plans for unsubsidized and advanced premium tax credit only individuals, and a largely stable product shelf compared to 2020, and moderate premium increases that, while higher than in recent years, vary by carrier. The overall 2021 premium increase for unsubsidized and APTC-only members, before accounting for the portion of the increase attributable to members aging 1 year older between years, is about 7.5%. The premium increase for underlying Connector Care Silver plans is about 8%, though Connector Care members are buffered from this increase by premium subsidies, and dental members will see significant premium decreases. And Kevin Began from the Division of Insurance has joined today's board meeting should anyone have questions about the 2021 rates. So as Louis, unless any questions, as Louis mentioned, the 2021 product shelf reflects stable plan offerings compared to last year, with the exception of some key changes for Connector Care members. There are no new carrier entrants for 2021, which is a change from what was shared with the board in July, when AllWays Health Partners preliminarily submitted for seal of approval as 2 distinct carriers. AllWays Health Partners no longer intends to sell plans under a separate select carrier license as initially proposed. Instead, it will offer a narrower select network silver plan under the existing carrier that will serve as its Connector Care offering. When we came before the board in July, we shared our concerns regarding the select network's provider adequacy related to Connector Care network standards and indicated the network may be insufficient to serve Connector Care members in some regions. In working closely with AllWays staff throughout the summer, we're pleased that AllWays was responsive to Health Connector concerns, and the select network has been expanded such that it meets Connector Care network adequacy standards in all regions. We'll discuss the select network in greater detail in the Connector Care section, and also want to note here that AllWays proposed regional coverage is unchanged since the information shared with the board in July, with Worcester County still removed from the current service area. So next, I'll turn it over to Sam to discuss the 2021 plan shelf and premiums in greater detail.
Thanks, Maria, and good morning. The totals presented today reflect a net decrease of 4 plans since the July conditional seal of approval on the non-group shelf. This accounts for the withdrawal of 5 plans from the AllWays Select carrier and the addition of 1 narrower network silver plan from the existing AllWays carrier. For consideration in today's final seal of approval, 9 medical carriers submitted a total of 59 non-group QHPs for the Health Connector's 2021 product shelf. This total reflects a net increase of 3 plans from 2020. On the small group product shelf, 9 medical carriers submitting 72 small group QHPs are proposed for the Health Connector's consideration. This total includes the standard low HSA Silver compatible plans and PPO offerings sold only on the small group shelf. This total also reflects a net increase of 3 plans from 2020. On average, the unsubsidized and APTC-only non-group members will experience a 7.7% rate increase before aging and 9.4% increase after accounting for aging. These increases vary by metallic tier as described below. You'll also see that the rate increase on the gold tier is lower relative to other metallic tiers. This increase can be attributed to the plan mapping recommendation proposed by the Health Connector, whereas some 2020 high gold members will be mapped within the same carrier into a low gold plan design.
Sam, do you want questions now or at the end?
Yeah, sure, yes.
And this may be a question for Kevin and maybe Rena. So we know that utilization for many health plans is way down because of coronavirus. And as someone who's looked at the financial performance of the plans, many of them are doing quite well as a result of that, including loss ratios and dental coverage that are at about 50% and much lower loss ratios. So I'd love to hear a little more about why in that context rates are going up so
Nancy,
much.
could I just chip in and say that you're right, that there was a decrease in utilization as a result of COVID, but I can share with you, because this is the work we do with our clients, and we've been talking to all the health plans, that the utilization patterns are actually now recovered, that dental utilization is actually surging because dentist offices have figured out how to operate safely. The biggest concern I see is actually the lower speed of take up in preventive care, but we are seeing emergency room visits go up. We're seeing inpatient utilization increase, physician office visits increasing, with the exception of private, actually primary care physicians. So there are about 8,000 primary care physicians in the Commonwealth. 4,000 of them are connected to a hospital system. 4,000 are independent, and they're really struggling through this process of being connected to the Commonwealth residents. So I would just say that there was a lapse or a decrease in utilization for a period of time, but it is coming back and coming back rather quickly. So and I understand that the health plans have also taken varying degrees of action as it relates to rebating because they're required through the ACA in order to do that in the small group and merged marketplace. So some of that's been done. Dental carriers have also given premium holidays to a number of their clients for the very reasons you said, that they are doing better financially and they have a fiduciary responsibility to do that.
Yeah, thank you, Mark, for that. Any of us, however, who've been in a hospital, as I have over the last couple of weeks, in a dentist's office, in a physician practice, know that because of the safety protocols that they've had to put in place, that they are nowhere near providing the level of utilization. I happen to go to the dentist. I don't know if that was advised from a public health standpoint or not. And my dentist says he's able to do 1/4 of the number of visits that he could do before. So I'd love to hear, just Kevin, maybe you or Gary could just say, like, what are you seeing in the rate filings? Like, we haven't had increases like this in quite a long time.
Yeah, thanks, Nancy. This is Gary. And thanks, Mark, for your comments as well. Maybe it's helpful just to back up slightly to just talk about a little bit about kind of the way the rate review process works here at the Division of Insurance and why we've asked Deputy Commissioner Began to join us today. So for those that may be unaware of about the process here at the division, Kevin, one of our internal actuaries, and work without external actuaries to, over the course of several weeks, to review the rate submissions by the various carriers. This particular process, I think, probably safe to say, has been one of the more challenging time periods. I think, if I recall Kevin saying, probably the most challenging in his 29 years here. And, you know, being here at the office every day and seeing it, I can attest to that. But just for, like I said, for those that are unaware, I, as the commissioner, I'm not involved in the rate review process. And the reason for that is, if in the instance that Kevin and the team that are reviewing the rates determine that there's a particular carrier's rates that are to be disapproved, there is a process by which that carrier is able to appeal that disapproval, and that disapproval appeal would come before a hearing officer here at the Division of Insurance. Our internal counsel would represent Kevin and our team, and a counsel for the carrier would represent them before our hearing officer, and that hearing officer would make a determination with a recommendation to me on to make a final decision on whether to agree with the disapproval or disagree with the disapproval. So just wanted to kind of outline that. And I think why it was important to outline that is, to your point, Nancy, I think it's been a real challenge. And there was certainly, as briefed by Kevin after the process, that we certainly got to that point about disapproval. So with that, I'll turn it over to Kevin, who can answer some of your more specific or questions, as he was intimately involved in the process.
Thank you, Gary. And I'm not sure if the board can see me. I'm socially distancing from Gary. And for the record, it's only been 26 years I've been here, Gary.
Yeah.
Actually, Nancy was involved 29 years ago. This has been one of the most difficult time frames. Nancy is absolutely correct. 2020 utilization went down dramatically in March and April. It is not quite at the level where it is up to where it was pre-COVID-19. The struggle we have is trying to predict 2021. Our big struggle in going through the company's rate filings was to look at how the trends have been evolving over the last few months and how that can be predicted for 2021. And in general, the biggest issues that arose in going through the filings were all of the uncertainty in predicting the future about how those trends may come back for 2021, how the severity of utilization may actually increase because of all the chronic care that was actually delayed or actually not gone through during 2020, the cost of the new vaccines as they do come about. And even in addition to that, the additional cost providers will be negotiating within their unit costs to account for the additional prevention and also PPE that they need to build into their service delivery. Despite this, the key to look at is that there are differences on a company by company basis regarding the level of rate changes for 2021. We did fight with all the companies to lower their rates, to adjust their trends. And we found that just about all the companies were willing to work with us and to lower their numbers. And by looking at the rate changes across the companies in the market, you'll see many companies are in the 4s and the 5s. We did have a couple of major struggles, most notably with Tufts Health Public Plan, which the board knows is one of the largest renewers for the connected care population. We acknowledged in looking at the Tufts Health Public Plan rates that their 2020 rates were lower than they probably should have been. This doesn't mean that the company is getting an increase in order to account for losses they may have for 2020. It's more to bring them up to a level that probably is more appropriate. I would say that even though we acknowledged with Tufts Health Public Plan that they did need a larger than expected rate increase, we did disagree on the 12.2% level. And as the commissioner identified, we delayed their filing and almost went through a disapproval process, which would entail a hearing that would have delayed the final rates for Tufts Health Public Plan probably until late October, November, once the hearing process was conducted. We talked regularly with the connector staff to understand the import that would have on the entire process, and we recognized it would cause mayhem, not only for the connector, but for all trying to figure out how to choose rates during open enrollment. In this process, we made sure that Tufts Health Public Plan and others were aware that looking at the second quarter rates, it would be a different world all around. We are expecting them to send in pre-filings on a couple of cases in December, so we can be aware of what they're planning to actually file in case we need to initiate a rate process much earlier. In this world, we definitely found this is one of the more challenging ones. I think the time frames to complete review is extremely short. But in answer to your question, Nancy, it was most difficult this year because of the dramatic uncertainty about 2021 in relation to what we're seeing for 2020. I agree partially with what Mark has said regarding utilization coming back. It's unclear how it will come back for 2021. There are complicating things, even adding right now that certain companies have already made premium refunds, most notably Harvard and Blue Cross. And we're aware that there are even going to be premium rebates that are going to be given in the next month for 2019 experience from one company versus another. But I would ask the board to recognize that each company is different. Tufts Health Public Plan did have rates that went up in a way we were uncomfortable for, but at this point, based upon the fact that their rates continue to be on the low end of the spectrum, we elected to go forward with this right now and intensify our efforts for the second quarter. I'll stop to see if there are follow-up questions beyond that.
Just a quick comment, if I may. This is Matt from the GIC. So we actually, at the GIC, have been, as you can imagine, following these trends very closely ourselves. We have the benefit of weekly premium feeds that come from our carriers. So we have a pretty good kind of real-time sense of some of these trends. And I would echo what Mark said at the outset here, which is that we've actually seen a quicker return of utilization, at least as it's being demonstrated through claims, than we might have expected. We are working very closely with outside actuaries to understand as best we can what the coming months and in fact the coming year sort of have in store. And I could just say that I sympathize with my former colleagues at the Division of Insurance who are dealing with a tremendous amount of uncertainty here, making it very challenging to come up with a number that really accurately reflects the best thinking about future trends. And in the case of the Q1 rates here and emerged market rates, you're essentially being asked to review the adequacy or reasonableness of trend that runs through the end of calendar year 2021. So at a time when there are just huge question marks out there that we are struggling with as well, I just, it's extremely difficult because you all have to actually come up with a number. We don't actually have to do that right now. We will do that later in the process of the GIC. We're actually having our outside actuaries present at our meeting, our next commission meeting next Thursday, with the specific assignment of reviewing kind of the best thinking about the future course of claims and COVID. And the best they can do is come up with a series of scenarios that are supported by a series of assumptions. And I can tell you that the output of those models is pretty wide. Again, further underscoring the challenge of doing kind of accurate forecasting at this time. So as somebody who was involved in the review process at the Division of Insurance, I know that you have a really challenging task ahead of you. I just hope that's helpful context from our vantage point.
Matt, if I could just piggyback on your comments and just add a little bit more context. We're seeing trends for our local plans. So the regional plans are in that 7 to 8% range, but we have seen trends as low as 4 and trends as high as 12. So to Matt's point, there's a lot of volatility, and a lot of volatility is coming from a lack of is a higher degree of uncertainty. So just to put a little bit more context into the comments.
Can I just ask one follow-up comment? So first of all, as someone who also has been involved in the rate review process in a prior life, I don't envy your role. I think what's difficult still to understand is when we talk about rebounding utilization, we're actually coming back to the level that was predicted when the current rates were set, which we know we have not been near. I guess that's the first point. So why we would suddenly be seeing, in some cases, double-digit rates of increase on rates that were predicated on higher utilization than we've actually seen and which we're not back at. I guess the second point is that some of the care that people have not gotten is not going to suddenly be made up for. Someone who usually gets a weekly therapy visit or a monthly check-in visit is not suddenly going to have 5 a week when they feel comfortable going back. I think I continue to be somewhat perplexed, knowing that you have much more detailed knowledge than I, but on the face of it, it's just very hard to understand, except explaining it in terms of real margins for uncertainty and maybe some attempt by some of the providers to make up some of the losses that they've had. So I don't know if unit costs are going up. So.
Can I jump in?
Yes, please.
Yeah, I have a few general comments. Much of this is in the spirit of what Nancy was saying. I understand we had a huge drop and now we have a big jump up, but you can't project the jump to where you can't continue that jump, right? And so we're clearly not where we were before, where we had a huge drop and a huge increase, but we're not where we were before. And of course, the rates are projecting that we will overshoot by a pretty significant amount. Some of that could be in the prices, as was mentioned, and we haven't seen what the prices are. I haven't seen what the prices are. Given the PPE and distancing things, I could expect some price effect. So rates might go up even with the same utilization. And I accept this is very uncertain. I do have a sort of 2 versions of the question. One is, there may be some assumption about a change in the risk pool that's built into here. And I'd be really interested to understand how much of these increases are due to some perception of a change in the risk pool. The second thing is, given the uncertainty, we have some protection. I know there have been some rebates and some refunds in the past. I know we have some protections given the MLR rules, but I don't understand those protections as well as I would like, and I don't understand the operation of them. So if it turns out when we're sitting here in 2022, looking back on the rates for 2021, and we realize, oh my God, it wasn't as bad as we thought, what happens then in terms of the MLR kicking money back to the people that paid? As an aside, I think it's not a very good system to overcharge people and then rebate them. People care about their money now, given the situation. So I don't think the sort of net works particularly well, but I can understand in this era of uncertainty that given uncertainty about the bounce back, uncertainty about the prices, uncertainty about the risk, uncertainty about the vaccine prices, uncertainty about a whole slew of other things that might have to happen, where a reasonable rate might be higher than I would project, but might not necessarily be unreasonable. If it turns out, reality turns out to be not as bad as the conservative fears that I think are probably built into this rate, how does the money get sent back to people and in what time frame?
And Mark, this is Kevin Began again, and to respond to both Nancy and your comments. First, for Nancy, I understand and definitely understand the perplexion she and we even feel regarding how to analyze the trends. I do want to stress, even in looking at the rate changes, it's probably important to look at Tufts Health Public Plan in isolation from the other companies. And that Tufts Health Public Plan had such a large increase that we put on file, not only because of normal trends, but because they were bringing to our attention as we saw that the rates they had for 2020 were actually too low. So it is something that they would highlight for us as part of the filing, that there did need to be an increase. And we were actually pressing for a single-digit high rate increase. And that was the dispute we had with them between where we actually ended up and what we wanted to see. To Mark's question, there is a process regarding rebates. Every year in July, this year in August, because of COVID-19, carriers need to do a true-up of the following calendar year to identify what the premiums collected are and what the claims payments are. And when they do that truing up, if through the calculations on the federal calculation worksheet, they fall below an 88% threshold, they are required to then make payments back to all of the persons who are covered during that calendar year. Through the process, we ask them to forward a plan so that they can give checks to the people who actually are no longer covered by the plan and give premium reductions to those who continue to be covered by the plan going forward. We are in the process right now of completing the 2019 truing up. And as part of that, there is going to be $44 million that is going to be given back to those persons who are covered by those companies in calendar year 2019. That process will happen again next summer, looking at the 2020 rates, so that it will then mean that in July and August of 2021, there will be rebates, I'm sure, given back due to the lower than expected experience for 2020. Any rebates for the rates that we are just putting on file will actually be done in July of 2022. But your point is well taken. It is something that we stressed very highly with all the carriers, that we needed to beat back any conservatism they built into their rate filings, because it was better for individuals to get lower premiums now rather than wait a year and a half to get any rebates going forward. That was factored into much of the deliberations we had with the companies. Many of the companies on our list specifically did revisit their rates and then lower them based on our negotiations back and forth. Tufts Health Public Plan, we were not able to negotiate that change, and it is the reason we were involved in deliberations with them until the end. Now that the rates are put on file, now that it is for an average of 12.2% rate increase, we will be doing the truing up. We will identify if indeed they fall below the 88% threshold, and at that time in the future, there will be rebate checks that are cut. Even some are cut in a way that for those who are on connector care, they likewise will get premium checks. There is also something that the connector itself is involved in certain subsidies for connector care population, where they at the connector do actually get some rebate that's forwarded back to them. But it is a process that is inefficient only in that it takes so long for the rebate to get back. But we make sure that we go through this on a deliberate process. And as I mentioned, for calendar year 2019, there are $44 million of rebate dollars that will be going back to people within the month of September.
So if I can just follow up, so I understand that in the profit numbers that Nancy mentioned, those are probably just the accounting wise, that's pre-rebate. So some of those profits are higher than they otherwise would be once those rebates eventually get paid back. I think that's true, although I'm not sure. So that's question one. And question two is, does the subsidy that the state or the federal government or any other people that are paying part of the premium share in any aspect of the rebate, or does it only go back to the beneficiary, which I guess if I had to pick is the more important person to go back to? But there's other people that are putting money in as the premiums, if the premiums are higher than they needed to be.
My understanding is that on the second question, the majority of the money goes back to the persons who have chosen the actual connector care policy. There is some amount that does go to the connector, and I'm not as skilled on that. Someone from the connector may need to answer that. But in your first question regarding reported profits or surplus, the companies are unaware what their final rebates are going to be for a calendar year until they actually do the final truing up. They do allocate some of that surplus or profit into reserves for rebates. And I think that some of the companies have already done that, but it's early for them to even know what the final rebate number will be for calendar year 20. But it is definite that some of the profits they may be getting right now will have to be then paid back as rebates to policyholders.
I mean, it's worth just as a data, United Healthcare made $6.6 billion in the first half of the year. So, and I know that this is a separately licensed plan, but seeing a 14% increase is really a bit hard to stomach.
And I can just confirm that the connector does receive a pro rata share of MLR that has been subsidized through state premium wrap. And I'd also just like to offer sincere thanks to DOI for all of their work in getting us ready for open enrollment.
I was just hoping to add a quick comment. I think it was really helpful to have the staff and the commissioner from DOI walk through this process, because I think that from a consumer perspective, as you're reading the news and you're seeing that healthcare costs are going down, but your actual lived experience is completely disconnected from that. I think it's really important for us to have an understanding of, one, the fluidity, but two, that there is a process carrier by carrier where there needs to be where there is push on the rates. And I just for the record, share Nancy's concern a little bit about this disconnect between what we're seeing being reported around healthcare costs and what is happening here. And so understanding the rebate process better is helpful. And I look forward to sort of how this smooths out as we move into 2021.
Thank you. Unless there are any other questions on slide 10, I'll just quickly explain slide 11. On this slide, we've modeled the range of monthly premium costs available in each metallic tier for the unsubsidized and APTC enrollees. This chart shows a minimum and maximum, as well as an average premium for an unsubsidized plan for each metallic tier. And this is modeled for a 42-year-old resident in Worcester selecting an unsubsidized plan. Unless any other questions, I'll turn over to Maria to discuss connector care.
Great, thanks, Sam. So in the next few slides, we'll detail key changes for the 2021 Connector Care program, including carrier geographic and network changes, as well as provide an overview of 2021 Connector Care premiums. We'll mostly focus on changes related to the AllWays Select network, but we first wanted to confirm, as Lewis mentioned in his opening remarks, that HNE Health New England will be expanding Connector Care coverage to Worcester County in 2021, as we had signaled in July, and HNE's rates are competitive in Worcester County such that they will be the lowest cost Connector Care offering in that region. And AllWays will participate in the Connector Care program under the existing carrier license, but with the smaller select network and a coverage area that does not include Worcester County. The approximately 550 AllWays Connector Care members in Worcester County would have access to BMCHP, Fallon, HNE, and Tufts Direct. And I'll talk a little bit more about provider options for those members in a later slide. And when we presented the conditional SOA to the board in July, we had identified areas of the state where the AllWays Select network did not satisfy Connector Care network requirements, specifically for hospitals. And since that time, AllWays has added hospitals to the Select network in Bristol, Middlesex, Norfolk, Plymouth, and Suffolk counties, sufficiently addressing our concerns. And we recommend that AllWays participate in the Connector Care program in all of the regions they had proposed. However, as the Select network is smaller than the current network, there will be some members who will experience provider disruption. The AllWays Select network is improved from the information shared with the board earlier in the summer, particularly in areas of concern identified by Health Connector staff. In July, in Bristol County, 27% of primary care providers, 40% of obstetrician gynecologists, and 14% of cardiologists in the broader AllWays network were retained in the Select network. Those percentages have since improved to 60% of PCPs, 50% of OBGYNs, and 35% of cardiologists. And overall, we're seeing that about 80% of providers in the current AllWays network are retained in the Select network. So while the breadth of providers does still vary by region, Health Connector staff determined it meets requirements in all areas. And the Connector Care member disruption associated with the smaller network, as reported by AllWays, has also improved. Health Connector staff shared a Connector Care member disruption rate of about 23% at the July meeting, and that has improved to just under 18%. So in addition to reviewing Connector Care networks to determine sufficient coverage to meet Connector Care access standards through the SOA process, staff also looked in greater detail at renewing member impact as described below. So starting with Worcester County, for the members displaced from AllWays in Worcester County, they will be mapped to the lowest cost Connector Care carrier available to them, which will mostly be HNE, but will be BMCHP for members in some areas of the county. Members would continue to have access to all hospitals in the region from a different carrier. Of the 9 acute care hospitals located in Worcester County, HNE covers 8 of them, Tufts Direct covers 9, BMC covers 4, and Fallon covers 5. In terms of members being able to maintain their existing providers in another carrier, according to the member disruption data provided by AllWays, all Worcester-based providers with disrupted members can be found in another Connector Care carrier's provider search tool data. In regions other than Worcester County, current AllWays Connector Care members would be able to remain with AllWays, but under the smaller Select network. And there are a few ways to look at provider access through other carriers. In all instances, the data is imperfect, but we can share a few statistics to give a window into the disruption for these members. So based on data from AllWays of providers, the providers associated with member disruption, about 85% of providers not retained in the Select network are available through at least one other Connector Care carrier's network. And when we restrict that to just PCPs, pediatricians, and OBGYNs, that number improves to around 90%. When we strictly use the Health Connector's provider search data that is preliminary for the Select network, the data reflects a slightly smaller overlap with closer to 70% of providers available from another carrier, but this may be an undercount as the select data is in draft form and has not yet been cleaned by our vendor in order to ensure a clear comparison. So in all instances, the Health Connector's communications leading up to open enrollment will strongly encourage members to review their current plan and providers, and AllWays will also send letters highlighting the network changes. As the year progresses, the Health Connector will receive network grievance information periodically from AllWays, such as access and open panel complaints, so that we can monitor the select network and adjust for future plan years as needed. The changes to the 2021 Connector Care Carrier regional participation are reflected in the map at the right, where in the chart at the left, you'll see carrier availability listed in order of premium cost, lowest to highest. Carriers in green have moved to a lower cost spot compared to 2020, and carriers in red have moved higher in the premium order. HNE in purple is new to those regions listed with its entry into Worcester County. In addition to BMCHP and Tufts Direct changing order in many regions, the most significant change will occur in Region B, and I'll discuss the member impact of that in the next slide. The 2021 Connector Care Enrollee Premium contributions, which can be found in the appendix, represent an approach that aims to maintain affordability and stability for members while promoting rate competitiveness among Connector Care carriers in a landscape with continued absence of federal cost-sharing reduction payments. Members in all regions will continue to have at least one Connector Care offering at the affordability schedule premium, and in many regions, members will have additional choices either at or near the affordability schedule amount. We're pleased to be able to offer some premium stabilization to competitive carriers for 2021. The 2021 premium stabilization approach provides the choice of 2 or more carriers at $0 for the lowest income members below 150% of the federal poverty level in nearly all regions. It also allows for affordable choices for Connector Care enrollees at higher income plan types, with several plans near the affordability schedule defined monthly cost in some regions. So Connector Care members on the whole will experience small premium increases in 2021. The Connector Care members that will experience the most significant premium changes from 2020 to 2021 are Tufts Direct members in Worcester County, or that Region B. So while 85% of all Tufts Connector Care members will experience a premium increase of $15 or less, members in Worcester County will experience higher increases up to around $60.
So this is, Michael, can I ask a question?
Absolutely.
Sure. I'm trying to reconcile in my mind the premium stabilization rules with the premium increases that we were talking about earlier with the material on the slide right before this, which is the one, slide 16. So Tufts Direct is the one that had the big premium increase that we were talking about earlier, if I follow correctly. And because they're red, they move to a higher premium position. I'm not sure if they went from first to second or they're just higher in the difference, but I think what's happening is that increase is causing BMC and Tufts Direct to flip in a lot of these regions. Is that basically right?
Yes, that's correct.
And so my question is the stabilization rules that we put in place dampening the beneficiary difference? So if you were in Tufts Direct before when Tufts Direct was lower, and now Tufts Direct increased their premium and now they're higher, it might be that the stabilization is shielding the beneficiary from that increase, depending on the actual gap in the stabilization rules that you just discussed. So I'm not sure my question was clear, but I'm trying to understand if our stabilization process is dampening the incentive for Tufts Direct to keep their premiums down because we're essentially smoothing it out when they went from the lowest to the second lowest. Do you understand the question? I'm sorry, I feel like I'm rambling. Maybe you don't understand the question.
Maria, can I take that one?
Sure, thanks, Audrey.
Thanks. Thank you, Michael, for the question. So the way the stabilization works, for some of the very lowest income individuals, it does sort of shield that difference, but the rate increases themselves don't result necessarily in the base rates for those two lowest carriers being all that far from one another, to be honest. And as you'll see from one of the prior slides that actually lists out the base rates, Tufts Direct and BMCHP remain very, very low in most parts of the state, certainly compared to others in the market. As you go up the plan type levels, as Maria noted, as people get a little bit higher income up to 200 and 300% of the federal poverty level, we're not designing the stabilization to mask entirely that difference. So it's still, you could effectively say, is sort of rewarding BMCHP for coming in lower. But what we're trying to do is sort of strike a balance between keeping that incentive you're describing that really does reward the carrier that comes in lowest, at least for many, many of the plan types and individuals in connector care, while also not exposing consumers to so much volatility that they're kind of flip-flopping around, particularly as it relates to the fact that they're not all on a level playing field from a silver loading perspective in terms of having to make up different amounts of lost federal cost sharing reduction revenue. I hope that helps kind of answer. So the kind of short answer is we're trying to sort of shield members from small differences, but we're still showing the rank order in enrollee contribution at the higher plan type levels in connector care.
So I have just a question or a comment, and I think I've gone on record with this comment before, so I just want to do it again. I am not a fan of premium stabilization or smoothing because I feel that at some point you've got to correct it, and it's very painful to make that correction. And I worry that this is reminiscent of some premium smoothing issues that occurred years ago related to another carrier that was in a very low position. And as they started trying to ramp up their rates, we tried to smooth the premiums and essentially pushed that premium increase onto the state instead of having the consumers have to kind of either make that choice or switch plans. So I just want to go on record saying I'm worried that we're starting this again.
Point well taken, Rena.
Yeah, just a couple of comments. The point is so registered, and I think if I were to draw a difference from the earlier circumstance, at that time we were doing a kind of flat leveling that carried up into upper affordability levels and corrected entire premium differences. And that did lead to a very difficult situation where when it became unaffordable to do that, we had to sharply pull back and there was significant disruption. This is a much more modest stabilization program than we've done in the past. We're trying hard to retain choice at the lowest levels, $0 choice, for two reasons. One is so that year over year you don't, you're just not met with the disruption of, well, this year BMC is $0, next year Tufts is $0. So we try to retain choice at the very lowest levels. But secondly, and I don't think this is a major factor, but administratively collecting like $3 premiums, which represent an affordability difference per month, it's an administrative overhead that is hard to, there's an investment in leveling at that level that prevents a lot of administrative overhead for all concerned. But Rena, your point is very well taken. I do think this program always needs to be, how would we say, minimally and modestly used.
Louis, could I add a contrarian view a little bit? Rena said she's not a fan. I'm a huge fan of premium stabilization. And I think to your point, the methodology and the amount has really become much more modest and more sophisticated over time. And I think it strikes a balance between giving carriers incentives to still bid aggressively, but protecting consumers against volatility. And I just would remind everyone that the income levels of people who are getting the most stabilization are extremely low. And where, you know, just a few dollars of additional premium a month are a hardship, and that the plans have over the last few years moved more and more to having limited networks that don't overlap. And so being able to give, you know, a couple of choices to people who can't afford even modest amounts of premiums so that they can keep their caregivers and their access to care, I think is a really important public policy goal too. So, you know, and I think this strikes a balance.
Thank you. Well, the next portion of the presentation moves on to the dental shelf. So any other questions on QHPs before we move on? Okay, great. So moving briefly to the dental shelf, there is no change to 2021 dental offerings with the same selection of carriers and plans as in 2020. And dental members will experience premium decreases in 2021 with an average decrease of about 10%. So unless there are any other questions, that brings us to the vote.
Great. Thank you, Maria and team. And I also just want to echo thanks to our colleagues at the Division of Insurance for all of their work, and for Kevin for joining the meeting today to provide additional context. So without further ado, I would like to move into the vote. So the Health Connector recommends awarding the 2021 final seal of approval to all recommended QHPs and QDPs proposed by the following carriers: AllWays Health Partners, Altus Dental, Blue Cross Blue Shield Massachusetts, Boston Medical Center Health Net Plan, Delta Dental of Mass, Fallon Health, Guardian, Harvard Pilgrim Healthcare, Health New England, Tufts Health Plan Direct, Tufts Health Plan Premier, and United Healthcare. Do we have a motion to approve?
So moved.
So moved. Second.
All right, and Kathy, can I turn back to you to do the roll call?
Of course. Commissioner Anderson,
Yes, and thank you to Louis and Audrey and the Connector staff for the work you've done.
Michael,
Yes.
Fay Ruth,
Yes.
Mark,
Yes.
Cassandra,
Yes.
Lauren,
Yes.
Nancy,
With extraordinary pain, giving a 13.5% increase to United, yes.
Matthew,
Yes.
Rena,
Yes.
Zarani.
Yes.
All right, the motion carries. And the recommendations are approved. All right. So the next item on the agenda is the 2021 Open Enrollment Outreach and Readiness presentation, which will be presented by Marissa Waltman and Jason Lefferts.
Good morning, everyone. Let me get this going. Okay. All right. Today we'll provide an update on preparations for open enrollment for 2021 plans. As in prior years, open enrollment will run from November 1st to January 23rd. And many thanks to Commissioner Anderson, as DOI will be issuing a bulletin aligning the off-exchange open enrollment period for individuals with this time frame. Our preparations have been underway for months and include updates to technical systems, member communications, and carrier engagement testing. This year, they also include considerations to reflect where we are with COVID-19.
The biggest changes to this year's preparations have been to account for the pandemic. First, we've been closely monitoring health insurance enrollment in conjunction with Mass Health, CHIA, and DOI. CHIA's latest enrollment monitoring report showed that from March through June, overall coverage in the Commonwealth actually increased by about 9,000 residents, though there have been sizable shifts where about 40,000 individuals have left commercial coverage, and Medicaid enrollment has increased by about 49,000 members. This year, we'll be messaging to individuals who may be looking for an alternative to COBRA or who lost job-based coverage earlier in the year and failed to take advantage of a special enrollment period. We've also adjusted our eligibility determination processes to ensure that members covered by Mass Health continued their Mass Health coverage for the duration of the federal public health emergency. And the emergency period is currently set to expire at the end of October, but it's already been renewed twice and it may be extended again. However, we're making sure that we're ready to support members as they transition to Health Connector coverage whenever they need it. And finally, as Jason will walk through, we're planning for remote forms of outreach and assistance in lieu of primarily in-person efforts. We kicked off member-facing activities in August when we began creating 2021 eligibility determinations. Members receive a letter notifying them that their 2021 application is available and they're asked to provide updates if needed. In October, we'll use the latest information we have, either based on our eligibility determination or the updates that members have made to map members to 2021 plans and send renewal notices that include their premium and subsidy amounts. In November, shopping begins and we send enrollment transactions to carriers for January coverage to ensure that all enrollees renew their coverage, whether or not they actively shop for a plan. And in December, we'll send invoices for January premiums, which are due by December 23rd. In terms of activity to date, earlier this summer, we sent members a what to expect mailing that outlines the communications and activities that are part of the open enrollment process. After that, we gathered updated information from external sources and combined it with information that we had on file to make our best estimate of a member's eligibility for 2021. However, we strongly encourage members to return to their applications to make updates as they know their circumstances best, and many are facing uncertainty with regard to their employment situation. And now I'll hand it over to Jason for details on our outreach and media approaches.
Thanks, Marissa. Good morning, everyone. As we get rolling into open enrollment, this period is going to require a reshaping of our outreach and messaging compared to recent years, which traditionally have been heavy on in-person community-based activities. That's obviously going to be limited due to COVID-19. I have hanging over my desk a map of the state where we kept track of visits last year. It's not very convenient, so I had Kathy send me a picture last night. We made 37 open enrollment related visits to communities last year. That's a lot, and we're not going to be able to do any of those this open enrollment period. So instead, the focus will be on a schedule of frequent social media based and digital opportunities along with increased paid marketing. The plan will continue to target communities with higher uninsured rates, but we'll also pursue new platforms or expand activities with trusted partners using existing platforms in order to reach those communities. With our public activities on hold, we're going to create a series of online and social media activities. This might include a monthly online learning series that focuses on particular parts of the enrollment process. We're currently doing those monthly meetings right now. They're a little broader in terms of the enrollment process. We'll be doing video interviews and other engagement in a range of languages with navigators and other community groups. We plan on a series of visibility events, such as a live concert series on Facebook or on YouTube. And we'll be doing a series of town hall events, similar to those that have been done by the Community Tracing Collaborative on the COVID side. Those bring together local community leaders and experts, and it's a way for people to ask questions and get answers from a trusted source. It's been very useful on the CTC side. We plan on bringing that over to the connector side during open enrollment. Over the summer, we did try out a handful of unique initiatives to try to create some community-based awareness to kind of fill that gap that's been created by COVID. Like I said, we did sponsor a live music series on Facebook in June. We've been at some pop-up drive-in movie theaters, providing informational material on a table or handed out when people kind of come in and pay. There's also on-screen awareness at those drive-ins in English and in Spanish. And we've been engaging with some of the supermarkets, some of the Latino supermarkets in particular, where there's still capacity issues where people are waiting in line. So there's material available outside. And it's also being put in their shopping bags when they leave. So we're trying out some new things, hopefully to get the word about open enrollment without actually being directly in person across the state. Education will continue to target communities that have traditionally had high rates of uninsured populations. We're not going to move away from that, but we're also going to include general messaging to those who have lost employer-sponsored coverage this year. That's going to include not only people who don't have health insurance right now, but also people who signed up for a COBRA plan earlier this year, just sort of as an automatic matter of course, and need to be aware of potentially lower cost options for quality coverage into 2021. Marissa, do you want to move forward?
I did, I think. Do you not see the earned and paid media slide?
Oh, I do. Yes, thank you. Sorry. Yep. Okay. So some adjustments are going to be necessary to better reach audiences this go around, particularly as we expand our audience types for this open enrollment. We are going to be doing additional paid marketing with the absence of our typical in-person activities. Like I said, we will certainly miss doing those visits, but we don't find it feasible to hold public events at this point. We'll continue our strong presence in ethnic media outlets, which have been good drivers of education and information in the past. In particular, local radio personalities with strong social media followings have been great partners for us during open enrollment. To better reach audiences, we'll be adding streaming TV and video. With more people at home, I look around, I see a lot of homes on the screen. Those streaming media outlets have become more popular in the last 6 months, and they do provide a good value proposition in terms of messaging. In earned media, we want to continue to focus on the availability of quality, low-cost coverage at a time when access to healthcare is more important than ever. We want to be sure to reach a broad audience to create awareness of the Connected Care program, again, particularly for those who might be in COBRA plans and over time have started to find the cost tough to carry. Additionally, we will be focusing messaging on the new Spanish language website, which was launched last month. This highlights a significant new feature for a population that has higher rates of uninsurance. And we actually did start that awareness around the Spanish website with a series of activities the last week in August. This year, we had to renew our Navigator grants for the next 2-year cycle. We have 18 organizations. That's the largest number of entities that we've had as Navigators, and the 100 people working in a Navigator capacity is the most since the program was created as part of the ACA in 2014. The Navigators, I think, as you all know, traditionally provide direct in-person assistance to residents in their communities who need help accessing health connector coverage. As we get into open enrollment, many Navigators will be providing virtual assistance to supplement more limited in-person help due to COVID-19. All 16 organizations from the last 2-year cycle return for the new round that runs through June 2022. We are adding 2 new organizations, the Lynn Community Health Center and Community Health Programs, which is headquartered in Great Barrington and has a handful of outlets up and down Berkshire County. In all, the organizations will house Navigators in 32 locations and can provide assistance in a total of 23 languages. And as always, people can find local Navigators on the website. The next slide includes a map and a list of the Navigators. As you can see by the red dots, we're filling in more and more of the state on a regular basis. As we get into open enrollment, we are trying to fill in another gap created by COVID in our walk-in centers. The walk-ins remain closed and will remain so for the foreseeable future. Members frequently use the walk-in centers to make a payment or process documentation. There have been new online features to support that activities this year. And members have made adjustments to their habits in the last 6 months to take care of those things as necessary, without going to walk-ins. We've not heard a lot of negative feedback on the walk-ins being closed, but in-person knowledgeable enrollment support remains vital to us and our members and new applicants. And to help fill in the gap created by the closure of the walk-ins, we are working on expanding some navigator capacity to provide additional help. Like I said, most navigators are providing some in-person support this open enrollment. It's mostly on an appointment-only basis. A few navigators do have very limited walk-in availability, but they're also doing a lot of appointments by phone and through Zoom and other online platforms. Navigator organizations are currently considering a variety of ways to increase their capacity for open enrollment, and we anticipate having a plan in place for additional supports in time for open enrollment. On member messaging, we realized the last 6 months have been difficult for members, and we want to make sure that if there's anything they need to do to maintain their coverage, they take care of it in time for January 1st. So we'll be talking to them a lot, as we often do, between now and that December 23rd deadline in particular. A few items in particular that we want to make sure members are aware of. If they need to update their income, they need to do that. That's something that has been particularly complicated this year as people go through employment changes and trying to account for new and different income streams like the federal stimulus and federal unemployment money. Members do need to provide documentation at this point. At the start of the pandemic, notices were sent, but the deadline for action was put on hold. Last month, those longstanding requests were sent notices that they had a 30-day window to submit their documents. The new reminders include a deadline and the information on what is owed. We do consistently remind members before and during open enrollment to provide necessary documents to make sure that they're eligible for the right program. We also want to make sure members have filed taxes. This is something that happens, every year. People need to file taxes to access subsidy in the upcoming year. There are always some people who don't do it. But this year there are changed deadlines on tax filings, so that perhaps makes it a little more complicated for folks. And we want to make sure that they take care of that business in time to be able to access subsidy again for next year. As always, we strongly encourage members to shop during open enrollment and to ensure they're in the right plan to meet their needs for next year. There are some network changes on tap. We've updated the online experience with a new network alert flag. We want to make sure that members see that, understand what it means, keep an eye out for it when they shop. And we'll also be reaching out to AllWays members to ensure they're aware of the changes going on with that carrier, and they can make a decision on their coverage for next year. And then I think here's the calendar for all of the member outreach for next year. It is voluminous as always. Jean Bernard does a great job for us getting the word out to members through email, direct mail. We typically do some robocalls here and there. So it's the usual high touch member activity through open enrollment. And then on the call center readiness, I think he talked about the state of the call center, but we will be open Monday, Friday, 8 to 6. We'll have extended hours on the big deadline days, which include those Saturdays leading up to the all-important December 23rd and January 23rd deadlines.
So moving forward, as I mentioned, our focus for October will be issuing those renewal notices to members with important premium and tax credit information. In November, we'll open shopping and send renewal transactions to carriers. In December, billing and payment for January are our key focus. And in January, members will continue to shop through the 23rd and will continue to send important communications, including tax documents for 2020 enrollees so they can file their taxes as needed. And through all of these phases of open enrollment, our primary goal remains offering members a stable and supportive pathway to the coverage that meets their needs. And we'll be monitoring economic and policy developments, particularly in this election year, and be ready to respond. And we'll continue to keep you apprised of how things are going.
Great. Thank you, Marissa and Jason and your teams. I want to recognize all the hard work over the last couple of months, in particular, in your efforts to engage and outreach to members during this challenging time, and for all the work. Oh, yep.
I'm sorry, I was trying to wait to the end of the presentation, but catch it before we moved forward. I just wanted to just recognize the connector staff and their outreach, especially to unions during the special enrollment period around our members who were losing ESI, given the large sort of furloughs and layoffs that people are experiencing across the sectors. And just wanted to lift that up as another opportunity for board engagement for those of us that represent membership base or have connections into organizations to help with open enrollment periods, because I anticipate that a lot of the sectors are going to continue to see a loss of ESI, and the Health Connector is an incredible resource. And so the webinars that were happening and the communication was deeply appreciated. And so I would just underscore that as another area of outreach, as well as a willingness on my part as a board member to help continue to make connections into some of those populations.
That's great, thank you.
Thank you. All right, and so finally, I'll turn it over to Audrey, who will provide a couple of key policy updates for the board.
Thank you, Lauren. Good morning, members of the board, and thank you, Fayruth, for that comment, which is a perfect segue into some of our policy updates in terms of how we've been attempting to be responsive to a lot of the economic tumult we know is going on around the state. So hugely appreciated, and open door to all board members who have ideas or channels that can help us get the word out. So thank you again. So this is really just intended to be a brief update for the board on some key policy topics that are of note and likely of interest to the board. And this is work we've continued to do even in advance of open enrollment, but really since last spring, in terms of trying to be an available coverage source and support for people who may be experiencing loss of jobs, loss of income, changes in coverage, as well as support for our own members who've already been in our coverage but may be going through hard times as well. A couple key updates on the federal and national health policy front that we're keeping an eye on that may have impacts down the road for us. And finally, teeing up for the board staff interest in coming back to the board in December for our strategic focused annual meeting with a framework for kicking off the Health Connectors work with a really intentional racial justice and racial equity frame. So starting with supports for individuals who may be going through job loss this year. As people may know, we have been working with the Division of Insurance and CHIA and Mass Health to really closely monitor what's going on in the health coverage landscape in Massachusetts. Of course, since spring, we've been mindful of job losses going on, people losing income shifts they may be experiencing. And the connector, like other exchanges, is really designed to kind of fit into those types of gaps people may be experiencing. There's some really interesting, compelling research out there about how exchanges and Medicaid expansion has really kind of helped fill a void for a lot of people who may be losing coverage due to economic downturns. Fortunately, we've been very fortunate to work with DOI, who's been collecting monthly data. Thank you, Commissioner Anderson and his team, collecting monthly data from carriers in Massachusetts to monitor any coverage losses we might be observing in the commercial market space. We've been really pleased to see that there actually has not been a huge atrophying of commercial coverage in our market yet. We've only seen about a 40,000 life change between, I believe it's April and July, which may be the latest snapshot that we have, with some people moving into Mass Health. But all in all, compared to some of the estimates we saw earlier in the pandemic, we've not seen the kind of losses that we were worried about. That being said, we know that we can't assume that that will continue to hold. There may be a lot of reasons that some coverage has been preserved for people, even if they may be losing jobs through an employer. A lot of the jobs that have been lost may have been people we and Mass Health already had. The data on the industries that have been hardest hit underscore that. That being said, people taking up COBRA that they may or may not be able to continue to afford, the PPP loans, more people being put on furlough than truly laid off, at least to date. All those dynamics are in the mix. So we just want the board to be aware that we're watching this really closely and see ourselves as having an immense responsibility here to help support people who may be kind of tipping off the edge in the coming months. So just to give the board a sense of some of the work we've been engaged in recent months on this front, we've been working closely with other state agencies, as I mentioned, our consumer sisters, our employer community, elected officials, trying to help get the word out. We were very, very fortunate to get to work with the Executive Office of Labor and Workforce Development, who kindly sent out a communication on our and Mass Health's behalf about health coverage options for people who are on unemployment income right now, specifically the population of individuals who are what's called permanently separated, so not furloughed, but truly had an end date with an employer. So a mailing went out last month to 336,000 individuals in that classification. So we were very grateful for the opportunity to get the word out that way. As Faye Ruth mentioned, we've been doing about monthly or so webinars for individuals who've lost job-based coverage. We're going to continue to do that. If there are board members that are able to help us get the word out about those webinars, we feel like it's a nice kind of easy way people can plug in and get the information they need, kind of walking them through the process of getting covered through us. We know a lot of the people who may newly need us have not worked with the connector before, so that assistance is important. And I should also note there's a link at the bottom of this slide. We include videos of each of these webinars so that people can go back and watch on their own time if it's not a convenient time for them to log in. And then briefly, as we've mentioned in past board conversations, we are continuing to work with DUA and their rapid response team, which goes out and engages with employers that are conducting layoffs for people, so that our information is kind of organically baked into the communications that they're issuing to people in the unfortunate circumstance of a layoff. And we are continuing to be linked to in the UI application for people themselves. We're also contemplating kind of ramping up in terms of direct outreach with employers who may be laying people off, just so we can help make sure we're making all of our resources available. And lastly, we've been working with our carriers to make sure that in the event that they are terminating commercial coverage for somebody through a group, through an ESI account or whatever the circumstance may be, that there is automatically information given to that individual about the Health Connector as a source of coverage, including the availability of subsidies to help make it more affordable. Turning to the supports in light of the economic downturn that we've continued to try to make available to our own members and to the uninsured or the already uninsured. As we've discussed in some past meetings, we're continuing to really rigorously message our own members about the importance of updating their own information if they have lost income. We've seen about 33,000 people through July actually move into lower cost coverage as a result of updating their information, whether it's reporting a job loss or a reduction in income. So that's really important, just to make sure people's coverage costs are right sized to their circumstances. And continuing to draw attention to the hardship waivers we have available for individuals in connector care who may be going through a particular challenge as it relates to housing, supporting themselves or a family member with an illness, et cetera, and making the process for applying for those easier. In terms of the uninsured, as the board knows, we did have a COVID-19 special enrollment period that we ran from March 11th through July 23rd. And thank you to the Division of Insurance who administered a similar SEP for the off-exchange market. We had almost 50,000 new people come into coverage during that time period. About half of them were through that COVID SEP. The other half were people that qualified for other special enrollment period triggers, like losing a job or some other life circumstance qualifying them. Our team, Marissa and Nikita, did a great and detailed brief that you can link to here that describes some of the demographic and other characteristics of the individuals who came in to coverage through that SEP and just newly into coverage through that period. They tended to be younger. They tended to live in the kinds of communities where we know there's higher rates of uninsurance. And for those who didn't qualify for connector care and so therefore had a choice of metal tiers, we saw them selecting more bronze plans. So just an interesting set of dynamics there. Turning our attention just briefly to the national landscape, just a couple of updates here to let the board know that staff are continuing to monitor and prepared to analyze as needed. The U.S. House passed a pretty significant piece of legislation back in June that one might think of as sort of an ACA 2.0 bill that had kind of a roundup of adjustments to the Affordable Care Act. This passed the House, is not going anywhere in the current Senate, but to the extent it's helpful just as a signal about possible policy developments that could be on the horizon, depending on various electoral outcomes. This has a number of changes that could affect us if this ever were to move, including key changes to the way APTCs and subsidies work. It removes the 400% of FPL advanced premium tax credit cliff. It actually increases APTCs pretty significantly for people below that amount. And just interesting of note for our board, actually would develop essentially a schedule for APTC subsidies that almost looks identical to Massachusetts's as it relates to our affordability schedule and RAP program at the affordability schedule. So that's interesting. It fixes the so-called family glitch and provides funds to states to establish reinsurance programs, state RAP programs, and interventions like auto enrollment and so on. On the judicial front, as has been the case for the last several years, no shortage of policy implications resulting from lots going on in the courts. As I think folks are aware, the kind of key ACA constitutionality challenge, which is now called Texas versus California, is going in front of the Supreme Court for oral arguments on November 10th. There are a number of other key ACA impacting cases that are working their way through the courts as well, including a recent decision from the Supreme Court on risk corridor payments that in an 8-to-1 decision was determined that are owed to carriers. That's in the amount of about $12 billion, and lots more to come on that in terms of what sort of shape that will take and implications for our market and others. Some important rulings on the federal shutoff of cost sharing reductions a few years ago that we continue to talk a lot about in our market, where a federal court determined that carriers are owed those payments, including for the last quarter of 2017. And lots more to come there in terms of kind of how those damages would play out, with silver loading also being in the mix. And then finally, lots of regulations and rules that are working their way through the courts, including on public charge, ACA Section 1557 non-discrimination rules, association health plans, short-term limited duration plans, and more. And then finally, as I noted in the outset, we wanted to just tee up here for the board's consideration that we are hoping at a staff level to adopt a framework for the connectors work on racial equity as we move forward in our own work, really with an eye towards the national discussion going on right now around racial equity that is so overdue, and really wanting to make sure that we're playing a part in evaluating how we can be helping to advance the ball there. And what we'd love to do is actually come back to the board in December as part of our annual strategic focused meeting that we have with the board each December, to talk about kind of a framework for that and a lens that would really allow for us to take a more intentional approach to making sure that the work we do is anti-racist and is helping address racial inequities in the healthcare and health access landscape as best we can. So wanted to put that on the board's radar to the extent that there are board members who'd be interested in working with us as we're developing that framework for the board's consideration in December. And we're in close contact with other state agencies who are thinking a lot about this and trying to find the right role for us as an exchange, playing a key role in coverage for the Commonwealth's populations. And so just to wrap up, looking ahead as always, we'll continue to keep you apprised on all of these topics. certainly national developments we'll continue to keep you apprised of. As I noted, we're continuing to work really closely with DOI and others on monitoring the coverage landscape in the Commonwealth and making sure that we're playing a role that's supportive and ensures that we don't have any residents falling into uninsurance and risking health and financial protections in that regard. And then we'll plan to return to the board with a more comprehensive proposed approach for consideration around racial equity and the Health Connectors work. I'm happy to take any questions.
That was a tour de force, Audrey. Thank you. That's in very short order. You covered a lot of material. So want to particularly support the racial equity and equity work more generally. So look forward to working with you on that.
Great.
I share Nancy's support for the racial equity work. What I wanted to comment on was, as you know, Audrey, I'm very surprised that we haven't seen a bigger change in enrollment following COVID. I was expecting a much bigger change. I'm not sure what to make of that yet, and I realize a lot could still come. We're certainly not past it, but I will say, to the extent that changes in risk were driving some of the premium things, if we're not seeing a lot of changes in the composition, I wouldn't expect a lot of changes in risk. So I don't know if it was built into the rates, but if they were assuming, like I was assuming, a big influx of people that would look very different, we at least haven't seen.
Yeah,
Michael.
It's such a good question, and we just don't know. And I don't know if there was any sense in that the carriers may have or others that some of the changes we may see in the coverage landscape are just being held off for longer and may occur later down the road. Whether that's true or not, we don't know. I mean, we think it's our job at the connector to be prepared for that possibility, if not likelihood. But yeah, it's a great question. We've been somewhat surprised ourselves.
I would just add that we're really lucky to have a very committed employer community. You know, the reality is employers are very committed to providing these benefits to their employees. And so that's also why you're not seeing a lot of churn where we would have expected a lot more. They're very committed to their role in the provision of employer sponsored benefits.
And I would just add from the GIC perspective that we also are keeping a close eye on enrollment trends, both drop off of enrollment or attrition of enrollment. As folks know, in addition to the state workforce that we cover employees through a number of municipalities and other offline agencies. So we're keeping an eye on the attrition, but also trying to keep an eye on too whether, or the degree to which our members are adding dependents, particularly spouses, to their coverage, to the degree that those folks may be losing ESI. And we actually haven't seen much of that either. So I guess I'd just say that our view on this is consistent with what others are saying here. And let me just say briefly too that, you know, I think we look at, I was on a webinar that Milliman did just recently about kind of the national view on the change in coverage. As you can imagine on these things, it varies widely by state. And you see some states, I think the range of the growth of the uninsured population varies from a +3 to a +18%, and varies widely based on, particularly based on Medicaid expansion, whether it's been adopted by a state. So I think just another reason why it's so important for us to have all the pieces in place that we have here in Massachusetts.
Thank you, Matt. Okay, thank you, Audrey. Sure. All right. Any final comments or questions before we move to adjourn? All right, well, I'm going to say thank you again to all the work, to Lewis and the Connector team. Really just done incredible, really, really important work over the last couple of months, both in doing outreach, maintaining stability in the market, and in preparation for open enrollment, which it's hard to believe that it's quickly coming upon us. So thank you for all you do. And with that, I will
call for a motion to adjourn.
So moved.
Second.
All right, and Kathy, one last time.
Okay. At right end. Commissioner Anderson,
Yes.
Michael,
Yes.
Fay Ruth,
Yes.
Mark,
Yes.
Cassandra,
Yes.
Lauren,
Yes.
Nancy,
Yes.
Matt,
Yes.
Rena,
Rena had to leave a little early.
okay, and Zaranique.
Yes.
That's it.
The motion carries, and so we are adjourned. Thank you, everyone, and stay well.
Thank you.
Thank you.
Thanks.
Thank you all.
Thank you.